Good morning everyone. So today's lecture is on restorative dentistry part 2. In this lecture we will be discussing about the modifications of cavity preparation and we will compare it with the permanent dentation or the permanent tooth. So moving on to the learning outcomes, at the end of the lecture we will discuss about the modifications of cavity preparation in the primary teeth and compare with that of the permanent teeth. So first we'll discuss about the conventional concepts and then we'll discuss about the modifications of the cavity preparation. So the conventional concept which is given by Blacks, that is G.V. Black, the principles of cavity preparation. G.V. Black has described the concept of extension for prevention of the cavity. So you have to extend the cavity preparation for prevention. So the basic idea is to prevent the recurrence of caries by placing the margins of the restoration along the self-cleansing areas. So why do we do the extension of the cavity in according to G.V. Black's concept? So that we place the margins of the restoration in the most easily accessible and the self-cleansing areas. In the incisors and canines, the margins of the proximal cavities are placed beyond the contact area, while in the molars and the premolars, the contact is between the adjacent teeth is broken. So for incisors and canines, what we have to do? We have to place the proximal cavities beyond the contact point, while in molars and premolars, we have to break the contact between the adjacent tooth. So the recent concept is with increased knowledge, prevention methods and advanced techniques and improved restorative materials, clinicians to follow both conservative and preventive criteria which can be met by construction with conservation. So our knowledge with time has improved and we have improved in a preventive methods or preventive techniques, and the restorative materials have advanced. Initially we used to use silver amalgam, for which we have to make the cavity depth to a specified height, depth and width, but with the newer advanced restorative materials which has adhesive properties, the clinician can have both conservative criteria can be used. So the restoration or the cavity can be constricted and there will be conservation of the tooth structure. So if we are using this newer advanced restorative materials, the cavity preparation has been reduced. It is less extensive preparation. So moving on to the anatomic difference between the primary and the permanent teeth. As you can see from the picture itself, that the primary teeth has a flaring roots while the permanent teeth has comparatively straight roots. So moving on to the differences, that is primary teeth has thinner enamel and dentine compared to that of the permanent teeth. The pulp horn of the primary teeth are larger in relation to the crown size than the permanent tooth. So in the permanent tooth, the pulp are slightly at a lesser height than compared to that of the primary teeth. The pulp horns of the primary teeth are closer to the outer surface of the tooth than the permanent pulps. So the pulp horn in the primary teeth, they are very close to that of the dentine, and the pulp horn, that is the mesobuccal pulp horn, is the most prominent. So there are times in which sometimes when we are excavating, we expose the pulp horn of the mesobuccal pulp horn of the primary teeth. So this is mostly due to the iatrogenic exposure of the pulp horn. So in primary teeth, the enamel rods of the gingival third of the crown extends occlusally from the DEJ, while in the permanent teeth the enamel rods extend in a cervical direction. So in the primary teeth it extends in the occlusal direction, while in the permanent teeth extends gingivally or the cervical direction. Next is the primary teeth demonstrates a greater constriction of the crown and have a prominent cervical contour than the permanent tooth. So the primary teeth has a greater cervical constriction. This is the reason why it is difficult to apply the matrix bands in primary teeth. The primary teeth have broad, flat proximal contact areas, while that of the permanent teeth we have contact points. The primary teeth are whiter than their permanent successors. The primary teeth have relatively narrow occlusal surface in comparison to the permanent successor. This is another difference, that is the permanent teeth occlusal surface has a higher surface has a wider surface area compared to that of the primary teeth. Moving on to the histological considerations, as I have some of it which I have already discussed, that the pulpal outline follows the DEJ more closely than in the permanent tooth. So as you can see, the pulpal outline, that is the resemblance of the pulp and the DEJ has close, they follow the same outline, and the primary teeth have longer and pointed pulp horns, the mesobuccal pulp horn being the highest. Then it has less bulk or thickness of dentine. So the thickness of dentine in primary teeth is less compared to that of the permanent teeth. And the primary teeth has larger pulp chambers, the thin enamel of uniform thickness which is parallel to the DEJ. So the primary teeth has thin enamel surface which is parallel to the DEJ, the dentine enamel junction. The enamel rods, which I have mentioned before also, it's directed occlusally for the primary teeth, while cervically for the permanent teeth. So the occlusal anatomy of the primary teeth is not well defined, and supplemental grooves are less common. So the cavity preparation should be kept more conservative. So in a primary teeth, what happens, there is no well defined or any supplemental grooves, so you have to make the cavity keep it more conservative. And even since the enamel thickness is lesser in primary teeth, you have to make the cavity shallow. So the pulp horns extend a greater distance into the crown of the tooth cavity and should be conservative to avoid pulpal exposure. So the pulp horn, as I have already told, that is placed higher, so it should be, the cavity should be conservative to avoid any pulpal exposure. And exaggerated cervical bulge, that is matrix adaptation, is difficult. Construction of the custom matrix to fit the teeth. So you have, since there is extensive cervical bulge, so the matrix adaptation is difficult, so you have to make a custom made matrix band to fit the tooth. As I have told before also, the direction of the enamel rods, so we will not be discussing again. The interproximal contacts of the primary molars are generally broad, which is actually a contact area, while that what we see in the permanent teeth is the contact point. So the interproximal is generally broad, elliptical, flat, and cervically placed. They are more cervically placed and they require wider proximal cavity preparation. So in primary teeth, if there is cavity on the proximal surface, it requires more wider cavity preparation because of its placement of the contact area, that is which is broad, elliptical, and it is flat and placed cervically. So moving on to the difference in cavity preparation in primary and permanent teeth is on the depth of the cavity. The depth is less in primary teeth while it is more in the permanent teeth. The occlusal table is narrow on the buccal lingual width of the tooth is less, while it is wider for the permanent tooth. Moving on to the contact point. So the contact point is, as we know, primary teeth has contact area while the permanent teeth has the contact point. So because of the presence of the contact area, the buccal and the lingual margins of the interproximal box must extend far towards the embrasure at the gingival margin to make it accessible. So to make to break the contact area, you have to extend the buccal and the lingual margins of the proximal box towards the gingival margin, so that it comes into the self-cleansing area. So this leads to more extensive cavity cutting. While in permanent teeth, because of the presence of the contact area, the buccal and the lingual margins of the interproximal box do not extend far into the embrasure area. So in permanent teeth, the contact point does not extend far into the gingival towards the gingival margin, so less amount of cavity cutting is required for permanent teeth. So in primary teeth, as we know that there is marked cervical constriction because of the narrow floor of the cavity, and this leads to placement of the cavity margin more gingivally. While in the permanent teeth, the cervical constriction is not that marked because of the sufficient width of the floor of the interproximal box and can be maintained. So in primary teeth, to maintain the cervical constriction is marked, because of which while preparing a cavity, the gingival margin it becomes too narrow, so you have to place the gingival seat more gingivally. So moving on to the isthmus of the cavity, the isthmus is narrow because the buccolingual width of the tooth is less, and cavities with wide isthmus can lead to fracture of the tooth. So in primary teeth, the isthmus is narrow, that is the buccal and lingual width cavity preparation is narrow, while in permanent teeth the isthmus is wider compared to that of the permanent teeth. Next is bevel in the cavus surface margin of the gingival seat. So in primary teeth, bevel is not given in the cavus surface margin of the gingival seat, while in permanent teeth, bevel is given in the gingival seat. The reason why bevel is not given in the primary teeth because of the placement of the gingival rods. The gingival rods are oriented occlusally, so in which the bevel, because of which the bevel is not given in the primary teeth, while in permanent teeth the enamel rods are directed gingivally, so bevel is given in the gingival seat. Moving on to the occlusal aspect of the proximal box. In primary teeth, it must be kept narrow to prevent the weakening of the pulp, while in permanent teeth, it's not that narrow. So the gingival seat placement are placed near of the contact with the adjacent teeth, so that the margins of the restoration can be clean, while in permanent teeth it is not that wide. So the gingival seat is wider for the primary teeth and not that wide for the permanent teeth. Now moving on to the slot cavity preparation. So these are the few modifications of cavity preparation compared to the conventional cavity preparation. So in the slot cavity preparation, as you can see in the picture, which is mostly for the proximal surface, so the lesion, if it is less than 2.5 mm below the crest of the marginal ridge, so you have a cavity or caries which is below the crest of the marginal ridge. So caries removal is by the proximal approach, so it is not involving the marginal ridge. So the caries approach is through the proximal surface, and it involves access to caries lesion from either occlusal surface, buccal, or the lingual direction. Use an approach that conserves the tooth structure. So in this, we have to use an approach that conserves the tooth structure. So it should be a direct approach to the carious lesion. So place bevel on all the cavus surface margins. This is for the retention of the restorative material. The advantage of the above cavity preparation, that is slot cavity preparation, compared to the conventional class 2 preparation is conserving the tooth structure and the marginal ridge. So this risk of iatrogenic damage to the adjacent proximal surface is minimized, and a normal contact area is maintained. So the advantage of the slot cavity preparation is you're not extending the cavity in or into a conventional class 2 preparation, in which you have to cut the tooth structure from the occlusal surface and the proximal surface. So this only removes the caries from the proximal surface or from that specified area only. You're conserving the marginal ridge, and the exposure to the pulpal exposure is minimized, and a normal contact area is maintained. So you have to avoid extending into the cementum, because the marginal sill will be difficult. So you have to avoid the extension of the cavity into the cementum, indicated when the adjacent tooth is missing. If the adjacent tooth is missing, so this is helpful in cavity preparation then. So as you can see here, in the anterior teeth you have proximal caries. So instead of cutting the whole tooth surface, here we can just remove direct vision, remove only from the proximal surfaces, and do the restoration. Next modification, we move on to the tunnel preparation. So this was introduced by Jinks in the year 1963. So if the cavity is very small and more than 2 mm from the crest of the marginal ridge, so this is mostly if the cavity is 2 mm below the crest of the marginal ridge, not involving the marginal ridge, and if the cavity is small, so we have approached the dentine lesion from the occlusal surface fossa just medial to the marginal ridge using a tapered diamond cylinder at intermediate high speed under air water spray. So in this, what happens, if there is a cavity which is there on the occlusal surface along with the on the proximal surface but not involving the marginal ridge, then we use the tunnel preparation, in which we approach the dentine from the occlusal fossa, that is from the occlusal surface medial to the marginal ridge, and we use a tapered diamond cylindrical burr at intermediate high speed, and along with that, basically in tunnel preparation what we are doing, we are avoiding the breaking of the marginal ridge. So the objective is to maintain the sound enamel in the marginal ridge. So you have to remove caries in class 1 lesions with round or number 330 ball. So you remove the caries in class 1 in the class 1 lesion, and when the ideal class 1 is prepared, that is once you have excavated the occlusal surface caries, then you prepare a small tunnel towards the proximal caries area using a small round bore. So once your cavity on the occlusal surface is prepared, now you move on to the proximal surface. So how you remove the proximal caries is by making a small tunnel with a round bore. So you have to carefully execute the tunnel using a hand instrument to remove the carious lesion in the proximal area. So once you have used the round bore and made a path, then you have to use a hand instrument. Use a hand instrument to remove the caries in the proximal area. The marginal ridge is kept intact. So for this tunnel preparation, the glass enamel is the best suited material for such cavities, as it easily flows into small cavities and has the ability to remineralize the enamel margins and any dentine on the axial wall. So for tunnel preparation, glass enamel is the best suited restorative material. What are the advantages of tunnel preparation is it can be used in small proximal carious lesions which necessitates the restoration, while the disadvantages large carious lesion where access is difficult, the tunnel preparation cannot be used, and if the overlying marginal ridge is subject to heavy occlusal or demonstrates a crack. If there's a crack on the marginal ridge, then you have to break the marginal ridge and restore it with a restorative material, or if there is a heavy occlusal force on the marginal ridge, there are the marginal ridge is subjected to fracture or a break after the restoration. So the advantages of tunnel preparation, it preserves the marginal ridge, which is a conservative approach. It is less potential for a restorative overhang, so there is less chances of restorative overhang. The perimeter of the restoration is reduced. So the perimeter of the restoration is reduced, decreasing the potential for micro leakage. So the smaller the restoration, the more the less amount of micro leakage that can happen. So the potential for disturbance of the adjacent tooth is also reduced. So the damage or disturbance to the adjacent teeth also reduced in the tunnel preparation. So what are the disadvantages of tunnel preparation? It's highly technique sensitive and it's demanding careful control of the preparation by the operator. So it is a technique sensitive procedure. The angulation of the preparation often passes close to the pulp. So since it is a technique sensitive, so when you are angulating the burr from the occlusal to the proximal surface, it is very close to the pulp. So there are chances of iatrogenic exposure of the pulp also. Visibility is decreased and caries removal is more uncertain, and caries detecting solution can be used for this. So the visibility is difficult because we can only visualize the occlusal surface and not the proximal surface. So the amount of caries removal is uncertain. So for this you can use the caries detecting solution. So fragile marginal ridge at least 2.5 mm apical to the crest of the marginal ridge, according to Mount in 1997. So the fragile marginal ridge, that is at least 2 mm 2.5 mm above the marginal ridge, should be intact. So in this picture, as you can see, the occlusal surface of the tooth, there is no cavity that you see on this tooth, but if the radiograph of the same tooth is taken, there is some amount of diffuse radiolucency that you see. So less invasive procedure that is used is the tunnel preparation. That is, cavity is prepared on the occlusal surface and then it onto the proximal surface. So the radiograph of the same tooth is shown. It's the tunnel preparation, where the axis of the cavity started from the occlusal surface and then from the proximal, where it has been cleared and then filled with a restorative material. So here the marginal ridge is intact. So this is the picture of the same patient, which shows the restorative, the post-operative. What we see is the restoration which has been placed here. So next, moving on to the proximal box preparation. So the proximal box preparation is that which is prepared without the occlusal step. So in this, there is no occlusal step which is prepared, only involving the proximal surface. So when restoring a small cavitated proximal lesion in a tooth, so it is indicated in the narrow proximal contact, allowing minimal facial and lingual extension. So in this, there is minimal amount of facial, that is the buccal or the lingual extension, and even minimal or no extension on the occlusal surface. And the facial and the lingual walls converge occlusally. So proximal retention locks, that is 0.5 mm at the gingival point angles, which are tapering at 0.3 mm at the occlusal surface, are prepared. So basically, in proximal box preparation, what happen, you have to prepare the proximal box retention blocks, which are at the gingival point angles. The facial and the lingual, that is buccal and the lingual walls, converge occlusally, and there is no occlusal step which is prepared. This is done in small cavitated proximal lesions in a tooth. As you can see in this picture, there is only proximal box involvement, very little, minimal amount of the occlusal, hardly extending into the occlusal surface. So the tooth has been excavated. So this can be restored by using only GIC or composite, and here a matrix band is been placed for the proximal contour of the teeth. Next, moving on to the minimal intervention dentistry. So this minimal intervention dentistry, or MID, is defined as a physiology of professional care which is concerned with the occurrence, early detection, and the easiest or the earliest possible cure of the disease on a micro level, followed by minimally invasive treatment in order to repair irreversible damage caused by such disease. So minimal invasive dentistry is basically, it's concerned with the early detection of the caries and then treating it on a micro level, which is followed by minimal invasive treatment to repair the irreversible damage caused by the disease. So in this, you have minimal amount of tooth cutting or tooth damage. This is treated at the initial stages, and if there is any repair that needs to be done for the irreversible damage changes, that can also be done. Moving on to the principles of MID is the four basic principles that apply to fulfill the description of the MID is: first is control the disease through the reduction of cariogenic microflora. So how do you control the disease? Is by either altering the oral environment to by reducing the amount of sugary foods, or by the application of topical fluorides and advising the patient with chlorhexidine. So first you have to control the disease by reducing the cariogenic microflora. So as if we alter the oral environment, so this alteration of the oral environment will leads to minimizes the demineralization, and this the application of agents such as chlorhexidine and topical fluorides reduces the carcinogenic microflora. Then remineralizing the early lesions. You have to remineralize the early lesions by using such as topical fluoride. Then perform minimal intervention surgical procedures as required. Repair rather than replace the defective restoration. So if a restoration needs to be if a restoration has failed, it's always better to repair rather than replace the restoration. So replacement of any failed restoration will lead to further loss of the tooth structure and subsequent weakening of the remaining crown. So once you are replacing any restoration, this will lead to weakening of the tooth structure, because you are going to remove some amount of the tooth structure along with the restorative material. So it's better to repair it rather than replacing it. So biomimetic materials and minimal intervention cavity design, it is often possible to repair rather than replace a restoration that has suffered a limited failure. So it's always better to repair a restoration rather than replace, because when you are replacing it, you are going to remove the restoration along with the tooth structure, and this will lead to weakening of the tooth structure. So the minimal intervention approach is by early detection and caries removal and restoration. So for early detection of caries is caries risk assessment tools. You have caries risk assessment tools by which you need to assess the patient's caries status. So this will again help in early detection of caries. Then visual and tactile and radiographs. So these three will help in early detection of caries. So caries removal and restoration. So this can be done by pit and fissure sealants and conservative adhesive restorations, or ART, air abrasions, lasers, chemomechanical caries removal. So if we have a small cavity or a pits and fissures with a slight amount of demineralization you see, then it's better to seal it with pit and fissure sealants, and if it is deep into either pit and fissure sealants we can do, or CAR we can do, or ART is by using only hand instruments or air abrasions and lasers. And next is the chemomechanical caries removal. So these are few of the minimal intervention approach. So the various minimal invasive techniques are pit and fissure sealants, the pit and fissure techniques, the ART, that is atraumatic restorative technique, chemomechanical caries removal, air abrasion, ozone, lasers, PRR, caries infiltration technique, the mini box restoration, and enzymes. So we will be discussing also about the infected and the affected dentine, because the type of dentine that has to be removed for restoration or for minimal cavity preparation. So if a tooth infected dentine, how do you differentiate if the dentine has to be removed or has to be left on the tooth surface? It depends upon if the dentine is infected or affected dentine. So a dentine which is infected dentine will have bacteria present in it, while the affected dentine will have no bacteria. So the affected dentine can be left over on the tooth surface, while the infected dentine has to be removed. In infected dentine, the collagen is irreversibly denatured, while affected dentine is the collagen is reversibly denatured. Infected dentine, it's not remineralizable, while affected dentine is remineralizable. That means once we put a restorative material which is like glass enamel, it will help in remineralization of the dentine. The infected dentine should be removed while affected dentine should be preserved. The infected dentine are in the zone 4 and zone 5, while the affected dentine are the zone 2 and zone 3. Infected dentine is stained by caries detector dyes, while the affected dentines cannot be stained. The infected dentine is soft in consistency, while affected dentine is hard and leathery in consistency. So this helps us in differentiating the infected and the affected dentine, and the dentine that needs to be left over on the tooth surface or it has to be removed. The affected and the infected dentine can be distinguished by the degree of discoloration, the hardness. If it is hard and leathery consistency, we leave it on the tooth structure, we do not remove it. If it is in soft in consistency, that means it is affected dentine. Staining to differentiate the remineralized and non-remineralized dentine. So the stains, the different types of caries detector dyes also helps in differentiating the remineralizable and non-remineralizable dentine. So moving on to the restorative materials which are used in the MID is the newer generations of materials which are known as smart materials and which are used in minimal invasive procedures. So the new composite resins which have success because they virtually reflect, refract and absorb light in similar manner as that of the natural dentition. So the restorative materials, the new composite resins have they reflect the light, they refract the light, so they look similar to that of the natural dentition. So the fluoride, as you can see in the picture, there is fluoride release from the resin modified GIC. The intraoral fluoride concentration, if it is low, there will be fluoride release from the RMGIC. If the fluoride concentration is high, the fluoride recharge into the RMGIC. So if in the oral cavity, if the fluoride concentration has reduced, so the restoration itself will release fluoride, while if the fluoride concentration is high, so the fluoride recharge will happen. So the fluoride from the oral cavity will move on to the resin modified glass ionomer. So the material that is biocompatible, biologically acceptable and not rejected by the adjacent vital tissues. So it is also safe to leave the softened, demineralized, affected but sterile dentine on the floor of the cavity if the cavity is then sealed with a biomimetic material that release calcium and phosphate fluoride ions that result in healing of the underlying dentine. That means if we have a cavity which the base of the cavity, if we feel soft, but there are chances of, if we excavate the dentine, there are chances of pulpal exposure. So we will leave this softened dentine, but we sterilize this dentine on the floor of the cavity, and we use a biomimetic material. So in our clinics we use dical, which releases calcium and phosphate. So once we place the dical on the tooth surface, the softened dentine, this will help in remineralization of the tooth structure and also heals the dentine. So moving on to the we differentiate the amount of fluoride that is released by the glass ionomer, the resin modified glass ionomer and composite, and the restorative approach also. So the advantage of glass ionomer is it releases fluoride, and adhesion to the tooth structure is by ion exchange. RMGIC has a command set, so you have more amount of working time on the tooth structure, and it has improved aesthetics compared to the glass ionomer cements. while composite has more conservative approach. While the disadvantage of GIC is poor strength, the RMGIC has low wear resistance and composite has polymerization, shrinkage and marginal leakage. So all these restorative materials has some of the other advantages and disadvantages. The composite being more aesthetically pleasing than GIC and RMGIC, while the GIC has high fluoride releasing compared to RMGIC and composite. The strength of GIC is poor compared to RMGIC and composite. There is more amount of polymerization, shrinkage in composite than GIC. Next we move on to the air abrasion or micro-abrasion and kinetic cavity preparation. So this is the effective alternative to the standard drill that we do, and this uses the aluminum oxide particles to cut the surface of the tooth structure. So this aluminum oxide particles come at high speed and cuts the tooth structure. So the advantage is it is painless. So pain during the tooth structure removal is eliminated and is or at least reduced. There is no vibrations during the cavity cutting, and the only noise that is produced is by air abrasion is similar to the vacuum cleaner sound, and so the child will have less amount of fear from it. The disadvantages: the practitioner's tactile sensation for the tooth removal is reduced. So the practitioner will not be able to differentiate, may not be able to perceive the amount of tooth structure that he is removed or he is removing, and the cost of operation is relatively high. So this is the conventional GV black to microdentistry that we have moved on to. So the conventional to tooth substances saving preparation. So according to GV black is extension for prevention, while in microdentistry it is prevention for extension. So extension from prevention is, that is, pit and fissure sealants has been, that is prevention for extension. Then we have drill and fill, that is box preparations only, that is filling without drilling, laser, air abrasion, chemomechanical caries removal. Then in GV black we have anesthesia, while in microdentistry there is no anesthesia because we use the adhesive restorative materials. And the next is GV black conventional method has been shifted to a microdentistry, where we do prevention for extension, filling without drilling, that is pit and fissure sealants, and then chemomechanical caries removal, and no need for anesthesia because less amount of cavity or tooth cutting is done. So in this picture, as you can see, the first picture, that is A, there is some amount of demineralization of the tooth structure and food impaction is here. So once the tooth is excavated, and then after which the restorative material, the tooth is restored with a restorative material which is a composite, which has been done. Here again we have, in the first picture we have a small tooth preparation, in which after which it's excavated using a hand instrument, that is a spoon excavator has been used. The glass enamel is being mixed, after which it is restored, any high points checked and sealed. So this is for pit and fissure before application of the restorative material, what we see, and after application of the pit and fissure sealants to seal. So basically it's preventing the extension of the cavity by application of a restorative material which is the patent fissure sealant. So in this lecture we have discussed about the minimal amount of tooth preparation that we need to do, and the difference between the primary and the permanent tooth in relation to the histological anatomical features, and depending upon the restorative treatment also that we can do. So I will be uploading some of the questions for the same. Any doubts, please clarify in the Google Classroom. Thank you.